So the first case is a 77-year-old female. She had a past history of lung adenocarcinoma. And we have diagnosed with the patient with lung adenocarcinoma with pleura effusion before. So currently she is under treatment, and the amount of cancer cell is decreasing, but we still can see scatter like adenocarcinoma cluster. So this is very atypical. You can see the nuclear size is markedly increased, vesicular chromatin, cherry red nucleolus, and the shape of the nuclear is different from one to another. This is more rounded, this is more angulated, and forming a three-dimensional cluster with eccentric nucleus and moderate amount of cytoplasm. So this is adenocarcinoma, and as what I just say, the amount of cancer cells scanned may suggest that some response of the treatment. However, there are still some cancer cell over here. The next specimen, the patient had a past history of gastric cancer, and this is from her ascites specimen. This specimen, I think there are some proteinaceous background, so the cell was like binding together with this background material. However, you can still see like typical morphology of adenocarcinoma, which is vesicular chromatin, vesicular nucleoli, and eccentric nucleus with a little bit like plasmacytoid changes. So this is also typical for fully differentiated adenocarcinoma of the gastric origin. The next specimen is from a 55-year-old male patient who had a past history of lung adenocarcinoma. This is his pleura effusion again. The patient has been under treatment. So in this specimen, you can easily appreciate that most of the cells are actually tumor cells. And the degree of atypia is even more prominent than the last two cases that we just see. The size of nucleus is markedly enlarged. The size of the nucleolus is basically bigger than the adjacent lymphocyte. And so, which means the patient is already have progressed disease, and the current treatment is likely ineffective. Yeah, so this is everywhere. So the prognosis of this patient should be bad. So in the pleura, in the cell block preparation, we have some cluster, but majority of the cell is like what we see in the cytospin smear, which is single cell. So we move to fine needle aspiration. This is from thyroid FNA. So on low power, we already see they are hypercellularity, and in the background is very clean without any apparent colloid in the background, and we have fragments of monolayer sheets. We also have some more like three-dimensional cluster forming a papillary pattern. So just on low power, we already suspect that it is a papillary thyroid carcinoma. So we will usually go to the higher power of this monolayer sheet area to check if the nuclear feature is compatible with the papillary thyroid carcinoma. So in here we see they are the cells of these cluster are mostly ovoid, and if you check the axial of the cells, they are just crossing with each other, suggests that this organization. So a lot of these cells also have grooving, and we should look carefully to see if we can find any pseudo inclusion. So here we do have a pseudo inclusion in the center. Okay, one of these. So this is typical for a papillary thyroid carcinoma. So for the PTC, in the background, you can occasionally see some multinucleated giant cell, just like this one. This is a smaller one. Let's see if we can find some bigger one. But the overall cytomorphologic feature is very much consistent with the PTC. So we call these TBS 6. So this is also a multinucleated giant cell over here. The next specimen, so we move to the pap smear. The next specimen is a little bit difficult. The patient, she is only 46. She had a past history of persistent high CO of the cervix, so she already received a total hysterectomy. After that, she developed vagina like precursor lesion. So she had the vaginectomy with a high CO like a diagnosis, and she has been followed up in our outpatient clinic regularly, and we have diagnosed with high CO, ascus high, etc. In this specimen, because the first thing that we know, the patient already have hysterectomy, so there is no endocervical component because there is no endocervix. Just on low power, you can see there is a very, very strange looking keratinized cells with a have you seen the animation called 胆大党 There's a 长发的那个会变身成长发的鬼女的头发，就是长相这样哦，这么长哦，it's amazing. Yeah, so this is definitely a typical keratinized cells. This is definitely not normal. So some of the cytotech, when they see a little bit of parakeratosis, they will get really nervous and they will jump to the diagnosis of SCC. But in the our cytotech code ask us this is just too low. Okay, so this one is definitely not normal. So you need to go to the other area to check if there is any abnormal component. So this one is abnormal, but this is definitely abnormal, right? So this is spindle. It is hyperchromatic. It is not superficial. It has higher NC ratio. So we should consider squamous cell carcinoma in this case, definitely. Okay. So ascus is just way too low. Yeah, way too low for this type. And because of the vaginal lesion, usually there would be more keratinization. So the tumor diastasis can be sometimes difficult to appreciate. So for example, in this area, the screener only dot something over here. So we see spindle cell, like some keratinites, some more intermediate with hyperchromasia, and this one is very strange looking, right? However, there's a bigger area just right over here. This is typical for tumor diastasis, necrotic pattern of the keratinized squamous cell. Okay. So this is definitely high CO. This is like a necrotic keratinization. and these also necrosis, and here this is also a like a very strange looking keratinized cell without nucleus. So this is tumor diastasis. Okay, so this is necrosis. So we do see some tumor necrosis over here. And just like in the thyroid aspiration that we mentioned about, sometimes in the smearing area, there are more cells at the at the edge of the smearing direction. So we go from the above. So this cell all looks very, very atypical, right? This is definitely not normal. You can see this again, this one. Right? Yes. And here, this is if you check the Dr. Papanicolaou's first edition of the Atlas, the SCC just looks like this, right? We rarely see something like this nowadays, but yeah. So I think the patient already developed SCC. You see this one. The amount of tumor diastasis is very scant. I think Japing got the biopsy of the patient. So we will correlate with the histology. I think there is already a SCC. So ascus is just way too low. We should call this at least high CO or above. So I'm thinking to call this SCC, but because we have a concurrent biopsy, so we just correlate with the biopsy. So we will wait for the result of the biopsy. Okay, so this is, I think this should definitely be SCC, okay? Then we have some low CO cases. So this one, and the background is a little bit atrophic. So we have superficial cell with binucleation and hyperchromasia, some with a little bit vague, like a clearing pattern. So this is suspicious for low CO. So again, prominent hyperchromasia. If you compare with the chromatin pattern with the adjacent intermediate cell, this is way too black. So here, again, we have multinucleation, vague clearing, koilocytic pattern. So we have a koilocyte over here. So I think this case is okay that we just call it low CO. So again, a different patient. So we have some superficial cell which is highly hyperchromatic, and the NC ratio remains still like low. So we have binucleation and the koilocity type of changes. Again, superficial cell, hyperchromatic, low NC ratio. So I think this is also okay. So we call the case low CO. Okay, that's it for today.